Hello, everybody. Good evening. Am I audible now? Is my voice clear? Please text me. Yeah. Okay. Thank you. So let us start today, and I wanted to show 3 to 4 cases. I'm just sharing my screen. Yeah. We'll start with a very simple case. This is a patient of almost 45 years old and had complaint of pain in the region of ankle and plantar aspect. So in the plantar aspect of the foot, the patient had complaints of pain. You can see these are the T1 images, sagittal, T2, sag. The doctor has advised for both, ankle and foot region. So pain is there in the plantar aspect of the foot. If you see, the inflammation is there more towards the plantar aspect of the hind foot. The straight case, actually, you can see here. What is this structure? This hypo intense structure is a plantar fascia. So if you see, the plantar fascia is fusiform and thickened. It is usually flat like this, but if you see here, it is fusiform and thickened. Yeah, plantar fasciitis. So it is at the insertion of the calcaneum. If you see the immediate subcutaneous plane above this plantar fascia, there is fluid signal, and also the underlying muscles are showing edema, and also the the calcaneal attachment, the calcaneum is showing hyperintense signal on PDFS images. So these are all changes we can expect in acute plantar fasciitis. You can see this is the marrow edema and underlying bone. This is the thickened plantar fascia. So other than that, what are other structures we'll look at? We'll look at is this usually sometimes the patients with plantar fasciitis, most of the times they have retrocalcaneal bursitis and Achilles tendinitis. So they coexist because both are related to the the footwear and way they walk, and more of foot dynamics. So that's the reason usually in the most of the cases they will have coexisting retrocalcaneal bursitis and also plantar fasciitis. But in this case, there is no retrocalcaneal bursitis. Actually, tendon is normal. We see other structures here. For completion, there's the tibiotalar joint. This is a tibiotalar joint, and this is a subtalar joint. So no significant fluid. This is a minimal fluid which is physiological. So that is other thing. So what are the parts of this plantar fascia, if you remember? So what are the parts of plantar fascia? There are three bands of plantar fascia. So if you see in this coronal image again, so we have three bands. You see this plantar fascia? Yeah, we're going back. Okay, we're going back. Yeah, we see something here. This is also plantar fascia. This is plantar fascia. Okay, this entire thing is plantar fascia. As you see, this is going and attaching at the uh, level of base of fifth metatarsal. So this is a lateral band of plantar fascia. Yeah, medial, lateral, and intermediate zone. So here we have this is the entire plantar fascia. If we go, this is the lateral zone or lateral band of the plantar fascia that is also inflamed. So why we need to know the importance of lateral band of plantar fascia? if you see lateral aspect of the foot and ankle region, if a patient complains of pain, especially in the plantar aspect, if you see here, this tendon which is down, yeah. So this is a peroneus longus tendon. So this is a peroneus longus tendon. This is a peroneus brevis tendon. In case of peroneal tenosynovitis, in the peroneal tenosynovitis, so or peroneal tendon like peroneus brevis or longus interstitial tears, the patient do have pain, and it can be a pain of peroneus tendon or even this lateral band of plantar fascia tears. We can have plantar fascia tears, interstitial tears, which can mimic the peroneal tenosynovitis or peroneal tear symptoms. Yeah. So that is the reason we need to look for the structure called lateral band or lateral zone of the plantar fascia. You can see this. This is the lateral. This is the intermediate one, and few fibers go and they form the medial. This is the medial. This is a medial, intermediate, and this is the lateral band of the plantar fascia. Yeah, that's it. So this is a straight case. Just wanted to start with this. Yeah. Next, next thing is, this is also almost seen most of the spotters. Yeah. Yeah. So this is an axial PDFS image. So what I'm showing, I see moderate knee joint effusion. So usually knee joint communicates with the bursa. So what is this bursa? This is a suprapatellar bursa. So knee joint effusion with the fluid extending into suprapatellar bursa. So this is a moderate knee joint effusion with the fluid extending into suprapatellar bursa. We can see here this is the posterior joint capsule, and there is a lot of fluid in the posterior joint beneath the posterior joint capsule also. So what is this? Is there any ACL sprain here? Do you find any ACL sprain or ACL tear, anterior cruciate ligament tear? Let us see it on T2 weighted images also. It's more of bulky ACL and showing a ciliary stack appearance. It's a mucoid degeneration of anterior cruciate ligament. If you see here, this is a mucoid degeneration of anterior cruciate ligament. So what is happening here? Yeah, mucoid degeneration. So what is happening here? What are all the signs we see here? There are multiple signs which describe this pathology. Yeah, this is the medial meniscus. So medial meniscus, what is happening with medial meniscus? There is a bucket handle tear. What type of tear is a bucket handle tear? So whether it's a horizontal tear or a vertical or longitudinal tear, please comment on. So this is a bucket handle tear. So if you see, this is a medial most portion of the intercondylar notch region, the tibiofemoral joint. And if you see yeah, so it's a longitudinal displaced tear. So there are different types of displacements, whether it is anterior displacement or whether it is displaced into the intercondylar notch or whether it is displaced posteriorly adjacent to the posterior horn of medial meniscus or lateral meniscus. So the displacement can happen any other way. So if you see, there is a bucket handle tear of the meniscus with flipped meniscal fragment seen in the intercondylar notch. There is some sign sitting over here. What is that sign? Double anterior horn sign. We call this double anterior horn sign. Here we can find some double anterior horn. So absent bow tie sign and there are like multiple signs. So and double PCL sign. If you see, this is a double PCL sign. This is one PCL and this is other PCL. So there is a double PCL sign. This PCL, what we are seeing is a flipped meniscal fragment of the bucket handle tear. So what do you write in a bucket handle tear? So bucket handle tear. So first of all, type of tear, that is a bucket handle tear, and whether the flipped fragment is displaced into the intercondylar notch region, or it is displaced anteriorly adjacent to the anterior horn, or displaced adjacent to the posterior horn of the medial meniscus. So those things we need to mention. So if you see here, this is a coronal image. If you see the fragments, the torn fragments, meniscal fragments are seen almost into the intercondylar notch region. So that is one thing. And sometimes there will be medial extrusion of the body of the meniscus. Whether there is any extrusion or not, we need to mention the extrusion. So that is with the bucket handle tear, and we need to look for any other associated ligament tears, like whether there is any because there is an injury which is driving the which is the cause of the tear. So we need to look for other ligaments and other structures within the knee joint. So yeah, so any other thing, what we saw, that mucoid degeneration of anterior cruciate ligament, bucket handle tear of medial meniscus, and there is mild edema of the anterior root of lateral meniscus. Okay, so this is all fluid which is communicating with each other. So communicating fluid within the joint. And look for medial collateral ligament and lateral collateral ligament also. Are we missing any tear? So not a significant no other significant pathology except for the bucket handle tear. So this is a case of bucket handle tear of medial meniscus. So this is the thing. And the next thing I want is this is a case of a 50-year-old female who has tingling sensation, heaviness, and restricted mobility within the fingers and hand. So clinician was suspecting carpal tunnel syndrome. So ultrasound was also done for the patient, and so as I told you, so this is a case of carpal tunnel syndrome. We are just looking at what are all the features we need. We will see in a MRI. So what are the features of carpal tunnel syndrome on an MRI or per se any imaging? So there is usually palmar bowing of the flexor retinaculum. If you see here, this is the flexor retinaculum which is bowing palmar aspect. So how do I do that? At various points I can do it. So what I'm taking is I'll just draw a line from the scaphoid to pisiform. So pisiform to scaphoid, and I see how much is the anterior bowing. So almost it should be more than 2 mm. So see, something around 2.8 mm is the palmar bowing of the flexor retinaculum in this case. So then what are all the other features we see in carpal tunnel syndrome? So yeah, so if this is a PD image, so we can see this is a median now. So what is happening to the median now? So this is at the level of what? This is the pronator quadratus. This is the pronator quadratus muscle. So if I am going, and this is the inlet of the carpal tunnel. This is inlet of carpal tunnel, usually at the level of pisiform. So what we need to measure? One is flattening ratio and inlet to outlet ratio, inlet to outlet area ratio. So how do you measure the area? So we take a closed polygon tool. Okay, let's zoom it. Yeah, so I'll take a closed polygon tool and just trace. Yeah, so I'll trace along the margins of the nerve. So then I'll get the area. This is the area. So 13.325 millimeter square is at the level of inlet, and then I'll measure at the outlet. So outlet, where exactly I measure? I measure at the level of hook of ham. So if I go down, if you see, yeah. Yeah, this is a hook of Hammett. Okay, at this level, I need to measure the median now again. So if I'm doing it, better to do on a T2 weighted image, that is 13.2. And here we can see the level of hook of Hammett. Almost the signal intensity of the nerve is also altered in this case. Okay, you see, this is a nerve here, this is a nerve here, and I'm tracing it towards the outlet of carpal tunnel. So here we see this is a nerve. So almost 8.9. So I do so 8.9 mm. So this is the at the level of outlet. So usually we do an area ratio of inlet to outlet. So if it is more than 1.4, it is usually significant for a what do you call carpal tunnel syndrome. So I'll show you the case again and just say me is anything I'm missing in this case. Okay, I'm just scrolling through. After that, I'll also tell what are all the other ratios we need to look at the corpus callosum, which carpal tunnel syndrome. Yeah. So I'm showing all the sequences. Please go through. This is the PD axial T2. This is T2. I'm missing anything. Just let me know. All the measurements are correct. Patient is also having carpal tunnel syndrome. Clinically, NCS or conduction study also showed it is carpal tunnel syndrome. Is there any abnormality I'm missing? What is this? This bright structure. The same thing I'll show you on T2. If you can see. What is this? And what are these two things? What are these two nerves which are sitting in the carpal tunnel? So this is a bifid median nerve. So bifid median nerve itself is one of the cause of carpal tunnel syndrome. So here we can see this is one head and this is other head. In between, what do you have? Yeah, bifid median nerve. So this is a bifid median nerve. If I'm showing you, there is some bright structure sitting in between. So this is a vessel separating these two heads of the median nerve. So that is a persistent median artery. So there is a persistent median artery here, and also there is a bifid median nerve. So I have measured something. I have made some calculations. I have took the entire thing. So if it is a bifid median now, well, should I take the entire circumference like how I have took previously? So for measuring the area, should I take it like this, or how should I do it? Should I measure the area of this? Yeah. Should I measure this entirely or take it separately? You should take it separately and add it. Area of this plus area of this will be the inlet median nerve area, and area of this and area of this, now two heads separately in the outlet, and we need to add those and divide the sum of the median nerve area in the inlet by the sum of median nerve area in the outlet. Then we will get this um, inlet to outlet ratio. Usually more than 1.4 it is uh, what do you say, the carpal tunnel syndrome. So we see more than 1.4. Then there is something called flattening ratio that you can take, because these both nerves are together and almost inseparable in the at the level of hook of hammer. Here we can do flattening ratio for this uh, in a combined way. Like I should take the width and the height. So if I take width and height and divide them, width by height, 66.7 divided by 1.3. So it is 5.1. There is significant flat the median now. So there is significant. When do you say it is flattening? It is more than 3. So if it is more than 3, then it is flattening. So there is significant amount of flattening in the outlet of the carpal tunnel at the level of, if you see, this is at the level of hook of hammer. Okay, you can see the hook, right? Yeah. So this is a case of carpal tunnel syndrome. Why I put it specifically is to show you the persistent median artery and bifid median nerve. So yeah. Other than that, do we have any other things? So what are all the things we measure is like cross-sectional area at the level at the inlet, cross-sectional area at the outlet, ratio of inlet to outlet. If it is more than 1.4, usually it is seen in carpal tunnel syndrome. Then other thing is flattening ratio, that is at the level of outlet, at the level of hook of hammer, we take width of the median nerve and AP diameter or height of the median nerve, divide width by height. If it is more than 3, then there is flattening of the median nerve. And one more thing, what we spoke is like flexor bowing of palmar bowing of the flexor retinaculum. When we draw a line joining the anterior aspect of the scaphoid bone and pisiform bone, if the flexor retinaculum is bowing beyond 2.5 mm, then is flexor bowing of the uh, palmar bowing of the flexor retinaculum. So those are the usual signs what we see on ultrasound and MRI in case of a carpal tunnel syndrome. So any other things we are seeing that there is minimal amount of fluid seen in the radiocarpal, ulnocarpal, intercarpal joints. Okay. So there is mild hyperintense signal noted in the foveal and stellar attachment. This is a stellar attachment. This is a foveal attachment of TFCC and mild edematous meniscus homolog. Okay. So minimal fluid is noted along the tendon sheath of extensor carpi ulnaris tendon. Okay. So minimal amount of strain is also there in the mild strain is also noted in the TFCC. So yeah. So this is the other case. And one more thing, which is which is shoulder. If you can see, it's a young adult of almost 24 years. Yeah, 24 years. I'm showing you the axial images, PDFs. Okay, these are the axial images. These are the coronal images. And see, this is the sagittal PD. Any diagnosis? I'm showing you again. These are the PD images. Okay. What is happening here? What is happening here? Yeah, that is there. Slap is there. Okay. What is this? Almost we are at 9 o'clock position. There is labral tear. Pasta. I have to see. Pasta is our partial atlas surface tear, no? So that should be there somewhere here. Okay, so here we can see there is marrow edema in the anteromedial aspect of the head of humerus. Okay, and if you see there is, yeah, reverse bank cut. Yes, so there is a bony fragment also, and also there is a labral bank cut. This is a reverse bank cut. Okay, reverse bank cut, well and good. What do you call a reverse hill sac? This is a hill sac. Hill sac is posterolateral aspect of head of humerus. There should be a bony depression or marrow edema. That should be occurring here. There is something happening here, that is reverse hill sac. That is called McLaughlin lesion. So that is called McLaughlin lesion. So McLaughlin lesion is a reverse hill sac lesion. So usually if there is a McLaughlin lesion, there is every chance the shoulder gets dislocated very frequently. So they need to do a procedure for that. That procedure's name is also McLaughlin procedure. What do they do in McLaughlin procedure? If my pronunciation is not understandable, then I'll just type the name of the lesion, McLaughlin lesion. So this is a name for, sorry, I pasted. Yeah. This is a name for reverse hill sac lesion or McLaughlin lesion. So in McLaughlin lesion, there is every chance of recurrent dislocation of the shoulder. So what do they do? This is the defect, right? So in McLaughlin procedure, they position this. This is a subscapularis tendon, right? They position the subscapular this tendon into the bony defect. So that will prevent and keep the humerus within the cup, that is within the glenoid. Okay, so along with that, so if you see there is a bony Bankart lesion here, so reverse Bankart lesion and a reverse hill sac lesion, and there is marrow edema which we can see, minimal joint effusion. Okay, minimal joint effusion. Other than magic angle, there is also mild tendinitis in the critical zone of the supraspinatus. So you can see here there is increased signal intensity also in the sagittal images. So other than that, what is there? There is a slap, superlateral anteroposterior tear with the tear extending into the biceps anchor. There is a slap to tear in this case. So this is a superlateral anteroposterior, superior labral anteroposterior tear with the tear seen extending into the biceps anchor. This is a biceps anchor. If you see this is a biceps anchor. So this is a superlateral anteroposterior with tear extending into the biceps anchor. There is a slap to tear. So other than that, what are all other things we have? Mild AC joint arthritis is there. Minimal fluid in subacromial and subdeltoid bursa. Okay, so the muscles of rotatory cuff are showing edema. Okay, mild inflammation and thickening of coracohumeral ligament and inflammation in the rotator interval. Okay, see this muscle edema sitting over here. Yeah, so this is a reverse hill sac and reverse Bankart's lesion. Yeah, this is all the cases I wanted to show, and keep it short and in 30 minutes. So I'm closing the session. Thank you. Thank you very much.